Good morning. The National Center for Patient Safety from the U.S. Department of Veteran Affairs in Washington, and we're delighted that we're joined today by Thomas Garthwaite and Mr. James Bajian. Gentlemen, thank you for joining us.
I'm Dr. Jim Bajian. I'm the director of the National Center for Patient Safety, and I was going to go first. Even prior to the much-quoted IOM report to Error is Human was issued, the VA had been aggressively attacking the problem of patient safety. In fact, all of the IOM's recommendations in this regard had either already been implemented by the VA or were in the process of being implemented at the time the IOM report came out, which was very heartening for us. Part of the VA's commitment to preventing medical adverse events that harm patients involved forming the National Center for Patient Safety, otherwise known as NCIPS, back in 1998. Our mission was clear: to maximize patient safety through minimizing adverse events that can harm patients, thus ensuring that our veterans receive the best possible care. To accomplish this, we needed to address several related challenges: the lack of a safety culture in medicine, a lack of an appreciation of the value of close calls and their analysis, and the misconception that assigning blame is of any real value as a technique for preventing untoward events that can harm our patients. We chose to go about this by using a systems approach because individual human weakness is almost never the basic reason for adverse medical events. They are usually due to a complex interaction of known and unknown system vulnerabilities. Traditional efforts, however, to fix these problems focused on blaming individuals rather than addressing the larger system issues with less than satisfactory results. We therefore developed and implemented solutions for these problems. How did we do this? Well, several ways. We did this by developing and providing our frontline staff with tools that they felt let them do their jobs better. These tools shaped their behavior in such a way that it was consistent with the new system we were implementing. This change in behavior then leads to a change in attitudes, which ultimately then allows you to start to really change the culture to one of a culture of safety. Application of these tools has led to an increase in reports of adverse events and close calls submitted to us, as well as an increase in the number of corrective actions that have been taken to prevent the recurrence of these events. The VA has seen on an annualized basis a 30-fold increase in events reported since the institution of this plan, and a 900-fold, not 900%, but a 900-fold increase in close calls reported. Close calls now make up well over 90% of all events reported, rather than, as was previously the case, less than 0.1%. These increases do not indicate actual increases in the number of adverse events and close calls. No, they rather are an indication of the increased willingness of people to disclose problems that has traditionally been unreported in all health systems. And basically, you can't fix what you don't know about, so that's an important thing. We believe that close calls provide the best opportunity to learn as they unmask system weaknesses even before a patient's injured, thus enabling preventive action to be taken before a tragedy can occur. This 900-fold increase in close calls reported also shows us that VA staff believe in and are actually implementing this program. We are now seeing over 4,800 actual fixes annually being implemented in our system as a result of this program. As an example, one of these involved the close call that report that involved VA's patient's potentially life-threatening problem with a pacemaker. As a result of our program, all VA facilities were alerted to the problem and a solution was implemented. We also convinced the manufacturer to implement a real systems level fix to really remove the problem, and this had impact worldwide, as this is one of the major suppliers of pacemakers on a worldwide basis. Thus, due to our program, a close call that would have previously been ignored had a worldwide impact, positive impact, I might say. We have also identified improvements that can not only improve outcomes, but make better use of our resources, a win-win from anybody's standpoint. For example, many patients, especially those in intensive care units, require ventilators to breathe for them. To keep their air passages from drying out, which would make them prone to pneumonia, humidifiers must be used with ventilators. One of our facilities discovered through the analysis of a close call that a particular type of humidifier had a design problem that was prone to actually shooting in 100% liquid into the patient's lung, effectively drowning them. As a result, they not only identified other humidifiers that did not have this proclivity, but also these changes can be employed at a savings of $110,000 per year per facility. This savings doesn't even include savings that would accrue from the injuries that are averted, increased care that would be required, not to mention human suffering. They're just some examples. I'd like to turn it over to Dr. Thomas Garthwaite, the VA's Undersecretary for Health.
Thank you very much. Good morning. The National Center for Patient Safety's impact is not limited just to the VA healthcare system. We found our program to be easily replicable in any healthcare setting. The key documents, tools, and training materials have the potential to be immediately transferable. To date, we've trained over 25 outside healthcare organizations in our methods, and some of them have already adapted and implemented those methods in their programs, including the Department of Defense, Cedars-Sinai Healthcare System, Dartmouth-Hitchcock Medical Center, and the University of Michigan. Secondly, the Joint Commission on Accreditation of Healthcare Organizations, the nation's leading organization for healthcare facility accreditation, used VA's patient safety standards as their model when preparing new national patient safety standards for all healthcare organizations this year. Thirdly, last year the President mandated that the Department of Defense adopt a patient safety system modeled after the VA, and the National Center for Patient Safety has been helping them implement that. And fourth and finally, VA has also been...
That's fine. I'm glad to hear the word finally. Please go ahead and finish up.
Finally, VA has been training and working with healthcare personnel from outside the United States in our patient safety methods. Countries like Denmark, Spain, Japan, and the United States have approached us. In addition to an impact on systems of discovery, the intervention... Okay.
Ed Dorn, you work it into the answer. Ed Dorn.
I'm impressed with this program, but I'm interested in the way in which you balance the need for full disclosure against the concern for legal exposure.
That's an excellent question. We certainly thought about that right off the bat, and we've done this in conjunction with not only our own legal folks, but our oversight committees on the Hill. We have a number of accountability systems, probably more than any other health system, wouldn't you say, Tom? Yeah. For this disclosure. In fact, full disclosure to the patient and their family has been mandated by VA regulations since 1982, where we tell them an event has occurred, that they have rights to pension benefits as well as how they can file tort. That is one system that operates in parallel to the safety system. So we already had a functioning system to handle accountability and disclosure, as you mentioned, but yet allow there to be a parallel sequester system for learning.
In addition, we found that there are rarely punitive damages if we disclose any errors to patients, so that one of our medical centers believes that overall the total amount of wards, if you fully disclose any errors to patients, is less than if you don't.
And in fact, some of these results were published in Annals of Maternal Medicine in December 1999, right? Yeah, 1999.
Susan Schwab from the University of Maryland. Let me ask a follow-on question to Ed Dorn's question. Let's say that you all ended up in the winner's circle here and were out helping to inform others about this innovation. You would be walking a very fine line, wouldn't you, in terms of how much you disclose without having others either scared by the information or receiving insufficient information. To what extent other hospitals, other medical systems don't have some of the disclosure rules that you already have. What would the implications be in terms of your ability to tell your story without the information being misunderstood or misused or frightening the public?
I'd say one of the main things to me is that we've found that there are very few things that you learn by adverse event that you couldn't have learned by close call. And because close calls don't really involve actual injury, there should be no litigation or tort obligation. So I think that's been the profound difference, the realization that our employees, once trained, can see the close calls, and we can learn virtually every lesson that needs to be learned by a close call instead of a death or an injury.
Yeah, I think a good follow-on to that is that close calls have been shown to occur anywhere from 20 to 200 times more frequently than the actual adverse event they're a harbinger of. So it provides a way to learn without having to have the tort problem. So it really helps to destigmatize it, if you would. Plus, since we're looking at system solutions, when you communicate systems, you're not necessarily having to identify who did what, because that's not really the value. It's what was the systems design that makes it better. So while the VA might be, you could say we could be embarrassed possibly, the individual won't be, and leadership, certainly under Dr. Garthwaite, has not been afraid, and we haven't been, to disclose what we learn, and we've done that on the Hill, on the record already, and with good results, we believe.
So clear.
Yeah, you talked about really been an explosion in the number of reports that you have of adverse events and close calls. My question is, shouldn't there over time be a decline in the number of reports of close calls and so forth as you have remediation. Isn't it a little perhaps too early to determine how effective the program is in terms of remediation, because you keep getting increases in the number of close calls?
Well, if I'm going to take the first crack at that, certainly I think you're right. What you would expect over time, and we actually have built into the system, I mean, 5 minutes isn't much time to go over it. We have built into the system not only what are the corrective actions, but how they're followed up, how they're measured, how they will be measured to show that they have the desired outcome and don't cause undesired side effects. So you fix one thing and break two others. So we would expect that reports of that nature, the specific nature that have been fixed, should go down. And overall, you might see reports go down, but there are other things that come up all the time. The big issue is that you want to have free communication of what's going on, so these things can be addressed right up front. So overall,
are hospitals safer? Are hospitals
because
safer?
Of what we've done? Yeah, I mean, we can show you tangible results. I mean, pacemaker, there's things like use of endotracheal tubes, the common way they're used in emergent situations result in 1 in 12 intubations, the way they put a breathing tube in during a cardiac arrest, end up going down into the esophagus, down to the food tube instead of the breathing site, the trachea, which results in bad outcome for the patient. We've implemented techniques that doesn't occur. That's a huge change, which is very cost effective and makes a difference. So there are a number of tangible ones that we can show you where those things just don't happen like they did before. So that's tangible outcomes. So once you've kind of killed one problem and it stays dead, it's not there anymore. So I mean, that's a real tangible, the kind of the gift that keeps on giving. It's something that doesn't happen anymore, and it has, perpetual good outcomes, or at least what we said. And there's no reason aviation has experienced that same effect. Once they fix it, it pretty much stays fixed.
Gentlemen, I'm afraid our time has run out. Dr. Garthwaite and Dr. Bajan, we want to thank you both. And Dr. Bajan, we'd also like to salute you, sir, for your public service as an astronaut. We read that you've been on 2 missions up, and you also helped to rescue the Challenger space shuttle from the capsule from the ocean floor. So we thank you for that as well.
Thank you.
Thanks a lot.